Well, welcome to this video. Now, I've had so many requests to look again at hydroxychloroquine, and that's exactly what I've done. And I've found a study from Belgium that gives fairly strong evidence, in fact I would say quite strong evidence, that low dose hydroxychloroquine is an effective treatment. It is an effective treatment. And it seems to lower the death rate by about 30%. Quite profound difference. And the key seems to be that they used a much lower dose than the other studies. Now, I am going to tell you briefly about 3 other studies as well that showed efficacy, that showed hydroxychloroquine does seem to be an effective treatment. But then we'll think about why studies have shown that it's not, and we'll talk about the recovery trial from the Centre of Oxford-based medicine, which showed no effect and discontinued it from the trial, and we'll talk about the World Health Organization's Solidarity trial, which did much the same thing, discontinued from the trial. And then, as time permits, we'll have a look at a study from Brazil as well, which shows no effect. But it seems the key factor that people have been getting wrong, and I'm just coming to the end of the bottom line now, just stick with me if you want the bottom line. The key factor seems to be that these studies gave too high a dose. Now, let's clarify what we're talking about here. We're talking about the World Health Organization, and we're talking about the Oxford Centre for Evidence-Based Medicine. They didn't seem to realise you had to give the right dose. Now, this is bemusing at best. Now, is hydroxychloroquine a new drug? No, we've been using hydroxychloroquine and its predecessor, chloroquine, for decades, absolutely decades, for many conditions. So it's not a new drug. This is a drug that's known. The side effects are known. The doses are well known, and yet the World Health Organization and the Centre for Evidence-Based Medicine at Oxford seem to get it wrong. What is going on here? This is bemusing. You know, there's quite a few things in this pandemic, and you just can't work out why people didn't seem to realise things or get things so wrong. Let me just give you evidence for that before I finish the bottom line, before I go into the detail. For those of you who don't have enough time for this video. Now, I've just taken this morning from the British National Formulary. Now, this is what all doctors and nurse prescribers and pharmacists in the UK use. It's absolutely standard. Hydroxychloroquine sulphate, indications and dose. Right, so D-O-S-E, dose. There's nothing hidden here. This is just obvious stuff. And if we look at it, we see that the normal dose is 200 to 400 milligrams daily. Daily maximum dose to be based on ideal body weight. Okay, so there's the dose. For most adults, 200 to 400 milligrams. This is absolutely standard public domain information. And yet, both of the studies that we're going to look at, the UK study and the World Health Organization study, didn't seem to realise this. So it's all very strange. Anyway, so that's the bottom line. If you want to skip this video, fine. That's good. If you want the detail, I'm going to give you the detail on the study from Belgium that shows efficacy, first of all. Then a few other brief studies that show efficacy as well. And then I'll show you why it seems these other studies got it wrong. Now, let's start off with this study from Belgium. Now, I know I'm on pretty thin ice here, so I know this has been a controversial topic. And to be fair, I've probably steered away from it more than I should have done. But everything I'm going to tell you today is based on my understanding of the science. My understanding of the science, and I'm going to give you the references for everything I'm going to say. So this is not opinion. This is my attempt to explain to you what these scientific papers are about. And the bottom line again, well, I know I've given you the bottom line already, but the bottom line is I'm convinced by this Belgium study. The data is, of as far as I can see, a very high caliber because they gave a lower dose. Now, let's go on to it. So this is the study from Belgium. Low-dose hydroxychloroquine therapy, right? So that's the study there. Now let's notice it's an observational study, so that's not ideal, as we know. We like randomised, double-blind, controlled trials when we can, but an observational study of 8,075 patients is a significantly large study. This is potentially good stuff, and it's fully published. It was published on the 24th of August, International Journal of Antimicrobial Agents. Now, the background that this study gives, and let me just give you a bit more background first of all. Most of the data here in this Dutch study, I know it's only just been published, most of the data was collected in April, May, at the peak of the Belgium epidemic. There was huge numbers of cases in Belgium, large numbers of fatalities. In fact, Belgium, I think I'm right in saying, had the highest death rate per capita in Europe, at least for a period of time. It was very severely affected. So they had plenty of opportunity to do this study. And they followed early World Health Organization thinking that hydroxychloroquine could be efficacious. So what Belgian authorities did, they included in national guidelines. So you had doctors all over Belgium reading these guidelines and prescribing low-dose hydroxychloroquine accordingly. That's where all this data came from. So over 8,000 patients. So the background to this study is hydroxychloroquine has been largely used and investigated as a therapy for COVID-19 at a total dose usually ranging from 2,400 milligrams to 9,600 milligrams. Now this is a very large dose, because remember, the dose that's available there for the world to see is 200 to 400 milligrams. No secret, public domain. You know, whenever you're writing up a drug at work, I don't normally prescribe, but whenever people that prescribe are writing up drugs, or I look up these drugs frequently myself, but you always look up in the British National Formulary, the NICE guidelines and the British National Formulary. It is definitive. If you don't go by those guidelines, you would be negligent. You would be professionally negligent. This is what we go by all the time. And the guidance there was clear. Let's look at it. Well, no, we've looked at it enough times. We'll look at it one more time just to be sure. I mean, it is what it's saying. It's 200 to 400 milligrams. You know, it's there. It's publicly available. No, and yet, let me just give you. I've just sketched out some of the studies that we're going to be looking at. Now, the Dutch study used 400, then 400 milligrams on day 1, and then 200 and 200 milligrams on day 2 to 5. So, in other words, 200 milligrams twice a day after that first dose. So that's what the Dutch study was giving. Now, the recovery study in the UK was giving 800 milligrams, followed by 800 milligrams after 6 hours. You know, absolutely incredible. Let's just remind ourselves of the appropriate dose in the British National Formulary, 200 to 400 milligrams. Why were they giving such a high dose? I am bemused. So they gave 800 milligrams stat, they gave 800 milligrams 6 hours later, then another 800 milligrams 12 hours after they gave that first dose. Then they gave 400 milligrams twice a day, 400 milligrams twice a day from days 2 to 9. Whacking great dose. And yeah, we'll leave it at that for now. So we can see the difference in those studies. And the World Health Organization trial likewise was giving much larger doses compared to the Dutch study that was giving way lower doses. So days 2 to 5, the Dutch study was consistent with the guidelines we've known about for decades. They seem to be aware of that, whereas the other studies didn't seem to be able to work out. I don't know. I can't quite. I'm struggling, as you see. I'm struggling to work this out. The impact of this hadn't hit me till I prepared for this video, actually. Right, in Belgium, off-label use, that means it's not officially used for that purpose, but it was, of low dose hydroxychloroquine, and they gave us a total of 2,400 milligrams over the 5 days. 2,000, so that's 2.4 grams, isn't it? Over the 5 days. 2,400 milligrams over 5 days. Low dose regime, so 500 milligrams twice on day 1, 200 milligrams twice on day 2 to 5, a total of 2,400 milligrams. So that was what they were giving in the Dutch study. Right. Now the method that the Dutch study used, multi-center design, which is good. Vast majority of Belgian hospitals were included. It's always good when you get different geographical areas. It was a retrospective analysis. Now, to be fair, a prospective clinical trial would have been better, but this is based on a lot of numbers, so it's quite convincing. They looked at in-hospital mortality in Belgium, and that was one of the outcomes, how many people died in hospital. But as well as that, they looked at the outcomes after 40 days. And they were able to put patients in groups. So there was no difference in the baseline characteristics. In other words, they weren't putting people with lots of comorbidities in one group, because obviously if lots of people had high blood pressure in one group and lots of people had normal blood pressure in another group, that would mess things up. But they didn't. They accounted for that. And they accounted for that using this tool here, which is the recognised comorbidities. Now, this is the hazard ratio. So 1.5, that means an event will be 50% more likely. That means it would be twice as likely. That means it would be 2.5 times more likely. So as we can see, all of these things here make death and adverse outcomes more likely. Male sex makes it more likely. Every 10 years of increasing age makes death and adverse events more likely. Chronic liver disease there we see makes it more likely. So they took into account all of these well-recognised comorbidity risk factors. So this is quite a clever study. And if you actually look at the people that were doing this, it's all clever mathematicians and epidemiologists and doctors from all over Belgium. So it's quite a sophisticated piece of work, actually. So they took into all those things into account. So no difference in baseline characteristics. In other words, they weren't comparing apples and oranges. They tried to put people of the same characteristics in the groups. Now, in the groups they came up with, they were, first of all, there was hydroxychloroquine alone with supportive care. When I say alone, they didn't give it with anything else. It was just hydroxychloroquine and all the usual care that the patients got, of course. All the usual care as well as. So the hydroxychloroquine was as well as the usual care. And then the second group, so that was the first group. And if you like, the control group, they just got supportive care only. They didn't get the hydroxychloroquine. So they get everything else they needed. If they needed oxygen, they get oxygen. If they needed antibiotics, they get antibiotics. They just didn't have hydroxychloroquine. That was the only difference between the between the groups. So that's good. They adjusted for demographics, as we said. They adjusted for all those things. The results: 8,075 patients with complete discharge data. Wow, that's impressive record keeping there from the Belgian authorities. Now, the hydroxychloroquine group. There was 4,500 patients in that. Good number, very good number, in fact. And in that group, 17% died during the hospital stay. In the group where there was no hydroxychloroquine, 27% died during the hospital stay. And for these numbers, that is a very significant result. The results of that arising by chance are minuscule. It's a very significant result. So they were the deaths in hospital. And they did a multivariable analysis, as I said, looking at all these different factors. You know, the obesity, the high blood pressure, the heart disease. They accounted for all that. And they still found mortality was lower in the hydroxychloroquine group compared to the non-hydroxychloroquine group. And the hazard ratio was 0.684. So in other words, if you had 100 patients surviving in the hydroxychloroquine group, you would only have 68.4 surviving in the other group. So it's reducing the chances of mortality quite significantly. If it was 1, it would be the same. If it was 1.5, you'd have a 50% greater chance of dying. So we see there's actually about 68. So there's over a 30% reduction there, which is impressive. A hazard ratio of 0.684. An impressive result, I feel. And also they did follow-ups for 40 days. And after 40 days, the group that had received hydroxychloroquine alone, 19.1% of those had died. Whereas in the group that did not get the hydroxychloroquine, 26.5% had died. Pretty convincing. Mortality in the hydroxychloroquine group was reduced, both in patients diagnosed in less than 5 days and more than 5 days. So even if the treatment was started late-ish after 5 days, they still had a significantly reduced mortality. Right, that's what the study found in Belgium. That is quite convincing. Now, the conclusion of the authors, they came to this conclusion. Compared to supportive therapy only, low-dose hydroxychloroquine monotherapy, that's just that on its own, with no other suspected antiviral agents, was independently associated with lower mortality. Let me put that another way. It means less people died in hospital with COVID-19 diagnosed and treated early, or even if it was treated later on in the symptomatic phase. So that is good evidence to me that low-dose hydroxychloroquine, let me rephrase that, correct dose hydroxychloroquine. Why am I saying correct dose hydroxychloroquine? Because we go by the British National Formulary that tells us what the correct dose is. So really quite impressive results, and really quite bemusing why the Centres for Oxford-based Medicine and why the World Health Organization seem to use such a large dose. And of course, the other great thing about hydroxychloroquine, it's generic. You can buy it for nothing. It's peanuts. I don't know how much it costs, but I imagine you can buy 1,000 doses of it for, you know, a few dollars. Literally $3 or $4 for 1,000 doses is the kind of price that I used to buy a lot of generic drugs when we used to export them to Romania in the early 90s, and that's the kind of price we were paying. Typically a few dollars per 1,000 doses for these generic off-license drugs. Basically, it's just a chemical, and it's dirt cheap. And obtainable in huge amounts at very high quality as well, with guaranteed quality, not a problem. Now, other positive studies. I'm not going to do these in detail, but there was this one here, for example, in France. So that study, that's the reference. Don't take my word for it. And the conclusion of that study was early diagnosis, early isolation and early treatment of COVID-19 patients with at least 3 days of hydroxychloroquine, and they gave azathioprine as well, led to significantly better clinical outcomes and a faster viral load reduction than other treatments. So they found efficacy of that combined therapy. It's not azathioprine, it's another one, I can't remember. We'll come on to it later on. It's an antibiotic. Risk factors for mortality in patients with COVID-19, a New York study. Hydroxychloroquine was associated with decreased in-hospital mortality. And when I put it in italics, these are direct quotes from the paper. And again, don't take my word for it, it's there, look it up. Click on that in the description, it'll go straight to it. And again, treatment for hydroxychloroquine. That's azithromycin. It's an antibiotic. That's the word I was trying to remember. Azithromycin. Azithromycin has been used sometimes because it's got in vitro in the bench. It's got antiviral properties, and it's got immunomodulating properties as well. That's why it's sometimes been used. But of course, remember, the Dutch study was not using erythromycin, it was just using hydroxychloroquine as a monotherapy. And of course, the reason hydroxychloroquine is used is because it's got these in vitro antiviral effects as well. So the theory for hydroxychloroquine and the theory for azithromycin are both good. The theory is there. Treatment alone with hydroxychloroquine and in combination with azithromycin was associated with reduced mortality. So that was saying giving the hydroxychloroquine alone as a monotherapy or giving it in combination with azithromycin, with both associated with reduced mortality. So quite a few studies there on the efficacy of low-dose hydroxychloroquine. Now, how did we get to this state where hydroxychloroquine has been virtually dismissed? Well, the recovery trial was one. And at the time, this looked pretty convincing, because this is from the Oxford Centre for Evidence-Based Medicine. This is not some Mickey Mouse organisation. But as we looked at, they were giving on this trial 800 milligrams, 800 milligrams, and 800 milligrams, 400 milligrams. So on this trial, they were giving 16, 17, 18, 19, 20. They were giving 2,000 milligrams in the first 12 hours. Let me say that again. On the recovery trial, they were giving 2,000 milligrams in the first 12 hours. The recommended dose is a maximum of 200 to 400 milligrams. Yeah. So, just briefly, this trial, we did look at this in detail at the time. Now, the numbers look good, and indeed the numbers are good. The hydroxychloroquine group got that many people. The control group got well over 3,000. So good numbers. Look it up here. It's all still there. It's all documented. Patients allocated to the hydroxychloroquine sulphate group, you got that fairly high dose, and that came out to 9,200 milligrams over 10 days. So much larger dose than the Belgium study, much larger dose than the British National Formulary tell doctors to prescribe. And the conclusion from the recovery trial was, of course, that it didn't work and it was discontinued. In fact, it was associated with an increased length of hospital stay, but of course it looks like they were giving way too much. WHO-led Solidarity trial, again giving very high doses, 9,600 milligrams over 10 days, and WHO dropped it as well. Didn't do further research on it because they said it provided no benefit in hospitalised patients with COVID-19. So what you could really call the two most reputable research bodies arguably in the World Health Organization led effort and the Oxford Centre for Evidence-Based Medicine Centre, seemed to get the dose wrong. Now, for the sake of balance, so let me just say, my working conclusion now is that the low-dose hydroxychloroquine has efficacy based on the Belgium data. That seems to be what it's saying. But for balance, what I want to do is give you another recent study published just in July. Remember, the Belgium study was published just on the 24th of August. That's bang up to date. But this is another study. Let's look at this one, and then we'll finish for today. Hydroxychloroquine with or without azithromycin, mild to moderate COVID-19 again, and this was in New English Journal of Medicine based on work done in Brazil. Now, this was a smaller scale study. 55 hospitals in Brazil. It was randomised, that's good. It was open label. Now, what does open label mean? Well, very often in clinical trials, we like them to be blind. Now, in a blind trial, the person getting the medicine and the person prescribing the medicine doesn't know that they're getting the medicine, or they don't know whether they're getting the medicine or whether they're getting a placebo. I did this in a study when I was a young staff nurse on coronary care, way back in the, a long time ago, 1988, I think it was. It was called the International Study for Infarct Survival. And we were working out whether this drug called streptokinase and streptokinase in combination with aspirin, which is a clot-busting drug, would work. So people would agree to come on the trial. So we would say to the people coming on the trial, come on the trial and we'll give you the best available treatment. That's guaranteed. But there's a 50% chance you'll get this new treatment as well, which did turn out to be brilliant, by the way. The clot-busting drugs, the thrombolytic drugs have absolutely revolutionised coronary care. So, you know, if I was coming in with a heart attack, you'd say to me, well, you get the best treatment we've got, or there's a 50% chance you'll get this extra treatment. So most people obviously went on the trial. And then what happened was we went to a box, and we had the bags of fluid, because we gave it as intravenous bags of fluid, and it had a number on it, and we didn't know whether it was the active thrombolytic ingredient or whether it was the a bag of salty water, and we just gave it and we recorded everything. And it was only the people that had the codes to that would know. So me, as the person giving it, the doctors prescribing it, and the patient receiving it, none of us knew whether we're giving the active thrombolytic ingredient or whether they're giving a bag of salty water. We didn't know. That's blind. But this wasn't like that. This was open label. And obviously blind is better, but this was an open label one, so the prescribers and the patients knew what they were getting. But they did have 3 groups, and it was controlled. Now, notice here, and this is the trouble with quite a few of these trials. They're actually based, if you're doing a trial, it's actually quite a lot of work. It's a lot of work. So, recruiting 670 patients is quite a lot. The last research study I did, I don't do much research now, but I did this research study, and I recruited students from the UK, Hong Kong, Cambodia and Kenya, and I wanted to compare the efficacy of educational interventions in these different cultures, trying out the same educational intervention in different cultures. And I think I recruited about 600 patients altogether. But I tell you what, that took some doing. That involved trips to Cambodia and trips to Kenya. I mean, I was teaching there anyway. But it involved a lot of travel, a lot of work. Okay, I didn't have a team. It was just me and people in the institutions there that were kind enough to help me. But recruiting 600 patients, 600 students in my case, was a lot of work. So for a study to recruit 667 isn't too bad. But remember, we're much more likely to get valid data from the larger numbers. And the Belgian study had 8,075. So the Belgian study had many more patients. Therefore, the validity of the data that we're likely to get from the Belgian study is likely to be much better. It's likely to be more valid. Anyway, let's keep going. 504 patients confirmed with COVID. Now, these were patients who weren't very ill again. They weren't the sickest patients. They're receiving no supplementary oxygen or a maximum of 4 litres per minute. Now, 4 litres per minute is a lowish dose. Typically at work would start patients off on 2 litres per minute. That would be the lowest dose that you can give realistically, actually. Very often give that with a nasal cannula, but 4 litres per minute would be a relatively modest dose of oxygen, a relatively modest amount. So these weren't the sickest patients they were dealing with here, and they had 3 groups, 1-to-1-to-1. Standard care group, they recruited 229. Standard care plus hydroxychloroquine, that's the second group. So that's the first group, standard care. That's the control group, really. Standard care plus hydroxychloroquine, 400 milligrams twice daily. So a bit of a higher dose than the bit of a higher dose than the Dutch study, because that gave 400 milligrams on the first day, then only 200 milligrams twice daily after that. So a bit of a higher dose. 221 patients, and then standard care plus hydroxychloroquine, 400 milligrams twice a day, plus azithromycin as well, which, as we said, is known to have probable antiviral and immunomodulating effects. Because remember, we don't want the immune system to get out of control, because that's what causes the acute respiratory distress syndrome, causing the alveoli to fill up with fluid, as you know if you've watched these videos before. Now the results in this Brazilian study, no difference in the need for ventilation, no difference in the deaths, no difference in the thrombolytic complications, that's the little blood clots that form in the blood vessels, no difference in the number of people getting acute kidney injury, that's acute renal failure. So they found no difference between these 3 groups. But it's a much smaller scale study. It's only 667, not over 8,000 patients. Having said that, you would expect to see something, but you didn't. Is there a contradiction here? Yeah, there does appear to be a contradiction here. They examined the clinical status after 15 days. Standard care was abridged at 1. Hydroxychloroquine alone, patients got 21% more. They got a 21% higher scale on the adjudication scale that they were using to monitor how the patients had done, and the higher the number, the worse the outcome on their scale. So that they were 21% more likely to do badly. So the hydroxychloroquine alone was having a negative effect, and the hydroxychloroquine plus azithromycin, their hazard ratio was 99, which means there was a 1% reduction in poor outcomes. So, but the big but is neither of these were significant. You know, it's only when you reach the 95% significant value that, so they can be ignored basically. It's not significant data. It's not significant data. I remember when I was doing my, I did a biology degree, and I did this really complicated study on different things, and it was comparing one group against another group, and you know, there was nearly a change in every group, but it wasn't quite at the 95% level, so it was really confusing. So I argued this, and I got the assignment back, and like in big red letters all over it, the examiner said, "Do not argue from non-significant data. Do not argue from non-significant data." In other words, if it's less than 95% likely, less than 95% chance there's a genuine difference, we have to assume there's no difference at all. So very frustrating for researchers, but if it doesn't reach significance, the result's not significant by definition. It's no good, and these didn't reach significance. And in this study in Brazil, they did find prolongation of the corrected QT interval. Now, this is often talked about with hydroxychloroquine with large doses. This is why it's so important to give the right dose, because it's quite toxic. Hydroxychloroquine and hydroxychloroquine are quite toxic in higher doses. If you give higher doses, there's a chance of heart not beating properly, what we call cardiac dysrhythmias. And a lot of people call them arrhythmias, but really they're dysrhythmias. And fitting is another possibility. So what they found, and several studies have shown that prolongation of the QT interval. So I'll tell you what this is. So in a normal heart wave, you have the P wave. The P wave is the contraction of the atrial myocardium. Then you have the Q, R, and S like that, and then you have the T wave. So that's a normal heart rhythm. So P, that's the Q down there. That's the R, P, Q, R, that's the S, and that's the T wave. So that's the normal heart wave. So that's the top chambers contracting, that's the bottom chambers contracting, and that's the bottom chambers electrically going back to normal, process called repolarization. So what these studies found was prolongation of the QT interval. So that's the Q there, that's the T there. In other words, that interval was prolonged, indicating usually there's trouble with the conduction of electrical impulses through the heart. And of course, if that's messed around with too much, the heart will not be beating properly, and it will potentially you can go into cardiac arrest. That's of course why we have to give the right dose. So there was slightly more of this in the Brazil study, but of course they were giving a fairly high dose. They were giving 400 milligrams on day 2, on day 3, day 4. You know, they were giving 400 milligrams twice a day, all the way through to day 7. Whereas in the Dutch study, I've got Dutch there, that's why I'm getting confused. It's Belgium. Sorry. If ever I've said Dutch in this study, I've meant Belgium. I get Holland and Belgium mixed up. It's the Belgium study that we looked at. It's that one. Low dose hydroxychloroquine study. Yeah. Yes, it's definitely Belgium, isn't it? So this is. Apologies to people in Belgium if I've said Dutch, but I meant Belgium all the way through. So in the Belgian study, they only gave 200 milligrams and 200 milligrams twice a day on days 2 to 5. So the Brazilian studies were giving a significantly higher dose. So it's not too surprising they did get some. No, they're not saying it was a big study, but there was some prolongation of the QT interval and elevated liver enzymes, indicating the liver didn't like the dose of the drug it was getting. But the conclusion of the Brazilian study, amongst patients hospitalised with mild to moderate COVID-19, the use of hydroxychloroquine alone or with azithromycin did not improve the clinical status at 15 days as compared with standard care. Now, unlike the Belgium study, they didn't carry this on to 40 days, which is disappointing. So there we go. This study in Belgium is a strong indicator of efficacy for correctly dosed hydroxychloroquine in hospitalised patients, and it seemed to have efficacy that was quite significant, even if the treatment was started 5 days after the patient's first symptoms. So there we go. That's interesting. So my conclusion is that this study does provide substantial evidence that low-dose hydroxychloroquine could be an effective treatment. So what needs to happen now is the Centre for Oxford-Based Medicine and the World Health Organization need to go back and look at this and saying, okay, we got the dose wrong last time, let's do these studies again with a proper dose this time and find out if it is efficacious. It's just a pity all this time's been has elapsed since their discontinued hydroxychloroquine from their trials. Thank you for watching as always.